So thank you very much, and thanks for the invitation to speak, Dimitar. And really, as you'll see, this is more musings on COPD phenotypes and how could we potentially optimally target therapy, and I suspect that we're possibly not really there yet. So those are my declarations. And as I say, oh actually no I didn't say, but for somehow or other I thought I had the 15 minutes that I had last time, Dimitar, so we may have plenty of time for discussion, which is not a bad thing. So just definitions, and Gary's given us some definitions previously. So the genotype, obviously, of an organism is its genetic makeup, but its phenotype is how the genetic and environmental factors come together to create the person's physical appearance and behaviour. But there's no implication of a mechanism there. And Gary actually coined the term endophenotype or endotype, which is a contraction of endophenotype, I think, Gary, isn't it? And this is within the phenotype, so defined by a distinct functional pathobiological mechanism. And other definitions, particularly targeted treatments. I think there's been a lot of discussion of targeted treatments of recent times and personalised medicine, and it's really currently the focus of much anti-cancer drug development. The use of molecular or genetic characteristics to customise treatment. But I think, as Gary's already alluded to, and we were discussing last night, despite the GWAS studies and lots of other studies, we're actually a long way from true targeted treatment. Well, Gary was talking about asthma, but also in COPD, or perhaps even more so in COPD. That might be something for discussion and a comment from Gary. So we're really still searching for useful biomarkers in COPD. But in terms of personalised medicine and personalised treatment, as a clinician, I find this quite weird actually, because I think we always hopefully personalise treatment when we're treating our patients. So a COPD phenotype should be able to classify patients into distinct subgroups that provide prognostic information and allow better determination of most appropriate treatment that alters outcomes. This comes from Meilan Han and a group in the United States. But we know that our patients have very different phenotypes. So these are a few of my patients, and I've presented here before some of these patients, and again, because I thought I was talking for only a brief period today, I didn't go into detail about them, but this is one of my gentlemen who's the sort of classic blue bloater, really. He's on home oxygen, doesn't really like using it, so you see he's not on any there. He's an obese gentleman, but sort of would fit into that sort of blue bloater grouping, I suppose. This is a man who's had lifelong asthma and has smoked. So he's got COPD, and one could consider him as being in that ACO, asthma COPD overlap group. And this is a lady who has emphysema and is a frequent exacerbator. And all of these phenotypes have been described. Now, when we think about phenotypes in the past, the classical phenotypes that were described were the type A or pink puffer and the type B or blue bloater, and this is dating back to the 1950s. And there was also a type X, which is an indeterminate group, which of course some of our patients fit into, but I won't go into here. So there were studies in the 60s of these two types of COPD, from London and Chicago, and what they found was that there were differing mortalities over 3 years looking at these two groups of people. So the people with the blue bloated phenotype had a worse prognosis, 36% mortality over 3 years compared with the type A people or pink puffers, and that was published, as you see, in Thorax back in the 60s. Now, I think that those descriptors probably then led on to the MRC and NOT studies of long-term oxygen therapy in the 1970s, which were published in the 1980s and showed benefit from long-term oxygen therapy in hypoxemic COPD. So if we think about it, the severe hypoxemic phenotype is a phenotype, and these people had improved mortality in those trials. And you know, that's a sort of central tenet, I suppose, of management of severe COPD is that we put those kind of people onto home oxygen therapy to improve their mortality if appropriate. Subsequently and more recently, there's been the LOT study, the long-term oxygen treatment trial, which looked at a group of people with moderately severe hypoxemia, so let's call them the moderate hypoxemic phenotype, who had a resting saturation between 89 and 93%, and a group of them, as you may remember if you've looked at this study in detail, they had to actually increase their numbers by bringing in patients who had exercise desaturation as well. So that was the group, moderate hypoxemia, and they had a composite endpoint of mortality and time to first hospitalisation. Again, started with mortality but weren't getting enough patients in. And there was no benefit in those primary outcomes or in any of the other secondary outcomes from giving continuous oxygen therapy to these people with moderate hypoxemia. So I think we've got there, in that group, quite a nice differentiation between responders and non-responders to oxygen therapy, looking at the severity of their COPD. So this allows us to optimally target therapy, and patients with moderate hypoxemia, I don't believe, should be offered oxygen therapy. If we look at the NET trial in the United States, quite a lot of those patients were on home oxygen therapy, and many of them would not have fulfilled criteria for receiving that. So when we think about COPD, this is just the old ATS 1995 non-proportional Venn diagram, but I think it's still quite useful in terms of how we think about our patient population. So patients may have chronic bronchitis without airflow obstruction, they may have emphysema without airflow obstruction, and they may have asthma without fixed airflow obstruction, but then within this dotted rectangle is the airflow obstruction group, so this is the COPD group. So people with chronic bronchitis may well have airflow obstruction, similarly emphysema, and there's this group of COPD with asthmatic features, as it used to be called, and then it became ACOS, and now it's ACO. So patients who have smoked but have a history of asthma would probably make up the largest group of those. And COPD really is an umbrella term, and it's quite a difficult term, I think. This has been looked at more recently by the New Zealand group. So this is a study from Thorax in 2008, and it's Richard Beasley's group. And they looked at a population-based study. So the patients had airflow obstruction, but they were not necessarily presenting with symptoms, and nor had they necessarily been diagnosed with COPD. So the large black rectangle represents all the patients that were contacted, and the clear circles within each coloured area represent the proportion of patients with COPD in each subgroup. So here we are again, harking back to that 1995 non-proportional diagram. This is proportional. So chronic bronchitis, airflow obstruction, emphysema, airflow obstruction, and then asthma, airflow obstruction. There's this non-defined phenotype here. But note that 50% of people in this study with COPD had overlap with asthma. Now, we all have our biases. I was talking to Peter Barnes recently at the APSR last weekend, and he said, oh no, 50% of people, that's far too high. But it just depends on the study you're looking at. Every study is different, so there's not a lot of consistency here. So what are the COPD phenotypes? I think what I see in my clinic, I sort of have in my head ideas of phenotypes, but whether they are really phenotypes, whether or not therapy ought to be altered based upon these phenotypes is unclear in my mind. So there have been multiple studies using cluster analyses and other techniques to describe different phenotypes of COPD, but there really isn't any consensus in the literature on which data are required for optimal phenotyping. And there's no consensus either on whether comorbidities should be included or not. And we know from the last sort of decade that comorbidities, the importance of comorbidities has risen in our minds, and certainly GOLD devotes chapters to it, and it's in GOLD recommendations, but should they be included or not? And we really still don't really know how to manage that group of patients. Prognostic indices such as BODE, for example, are not said to be not substitutes for phenotypes, particularly by this group of Han et al. And we need to prospectively validate phenotypes using clinically meaningful endpoints, and that really hasn't been done very well as yet. So some of the phenotypes that have been described, we mentioned the population study phenotypes, but there are also phenotypes described from clinical cohorts. For example, the frequent exacerbator phenotype from the ECLIPSE studies, where the ECLIPSE studies showed that the more one exacerbated, the more one exacerbated. So frequent exacerbation predicted further frequent exacerbations. The systemic inflammatory phenotype, also described in the ECLIPSE studies. And recent Spanish guidelines have described 3 or 4 different phenotypes with what they've said are clinical, prognostic and possibly therapeutic ramifications. So they've described the COPD asthma phenotype, which I think we all recognise clinically, the frequent exacerbator and an emphysema hyperinflation phenotype. And what they propose in their recommendations, in their therapeutic guidelines, are treatments based upon these phenotypes, but the studies that have shown the benefits in some of these therapeutics are not necessarily based upon the phenotypes. So I think this is, again, a work in progress. I suppose GOLD is a work in progress as well. The ABCD grid is a work in progress as well. So long-acting bronchodilator is basically for everybody, if symptomatic. But if exacerbating or asthma, add inhaled corticosteroids, and Christopher's going to talk about inhaled corticosteroids in a moment, and whether or not we agree with this. There may be a place for mucolytics, although that seems to be quite small, PDE4 inhibitors, which we don't really have here, and macrolides, which we, I guess, are trying to reserve for the more severe end of the spectrum because of other issues to do with resistance and what have you. Some other features included in different phenotypic groups talked about by other authors. Bronchiectasis, of course, we know is a significant comorbidity in many of our patients with COPD, and again, that's up to 20%, 40% in different studies. Degree of emphysema, we've mentioned the systemic inflammatory phenotype, and then obviously, extremes of age, differences in degree of hyperinflation, and differences in degree of reversibility. And some of those obviously overlap. Then we've got neutrophilic versus eosinophilic phenotypes, IgE elevated, pheno levels, PAC years of smoking, symptoms, the comorbidities I've mentioned, and then other inflammatory markers and multiple candidate biomarkers. The comorbidities is an interesting one, and I just wanted to touch on something here. Again, it's more musings rather than giving you take-home data. So we don't even really understand the comorbidities that well. What are the associations related to? Are they due to the common risk factor, in particular the risk factor of smoking, to systemic inflammation, to decreased physical activity? But there isn't a worsening of prognosis associated with increasing comorbidities. I just thought that this was an interesting comorbid phenotype and was musing about its importance. So I came across this study in PLOS One, which was looking at COPD and coronary artery calcification on CTCA, the so-called CAC score, delightful. So in patients with COPD versus controls, for the same degree of cardiac calcification on CT scan, the COPD patients had more cardiovascular events. Why? The only difference that they could see between the groups, and I haven't shown you in the table that they had in the paper, the only difference between the groups was the level of beta blocker use, which was significantly lower in the patients with COPD. 5 minutes. Thank you. And that's the difference here. So I'm proposing a phenotype which maybe hasn't been proposed before, COPD with coronary artery disease, giving a higher risk of cardiac events because of inadequate beta blocker treatment. a poor prognostic phenotype perhaps that warrants treatment, and we know there's quite a lot of interest in that, and we've heard from Bob Hancock's in the past, and we ourselves are looking at doing a prospective study initiating beta blocker therapy in patients who have acute exacerbations of COPD. The eosinophil phenotype, no doubt Christopher's going to talk about this, targeting therapy according to eosinophil level. It's a confusing picture is all I can say. Small prospective studies showed higher sputum eosinophils were associated with greater oral corticosteroid response back in 2000, and that was a study by Breitling and Pavord. Blood eosinophils have been found useful to direct exacerbation therapy with oral corticosteroids in a study by Baffadel. And there are a number of retrospective studies suggesting that blood eosinophils may be useful markers of the likelihood of long-term inhaled corticosteroid response in exacerbations. But we're aware that retrospective and cohort studies previously, for example with statins, have not been shown to be necessarily proven in prospective studies. So I'll just flip through that. But the FLAME study of LABA-LAMA showed a greater reduction in exacerbation compared with LABA-ICS and did not find a greater response to the inhaled corticosteroid-containing arm in high versus low eosinophils, defined a priori. So again, more work needs to be done. So I would propose that phenotyping is only one element of my clinical assessment, which needs to include a careful history, including work history, childhood and other exposures, history of atopy and family history, clinical examination with targeted investigations. Targeted treatment also includes general recommendations suitable for all patients with COPD, such as smoking cessation, pulmonary rehab, immunisation update, inhaler technique, device choice and preferences, etc., etc. There are multiple ways of defining phenotypes, but at present many of these are descriptive and not associated with specific outcomes. Targeting treatment to phenotype is possible already. There are some clear phenotypes where phenotype predicts treatment response, such as, for example, the hypoxemia, as I've mentioned. I think there's a potential to think of phenotypes in different ways. For example, the example of the undertreatment of with the beta blockers. And the importance of eosinophilic phenotype is unclear and still evolving. And I think that we practice medicine as an art, not a science, and I'll leave you with the words of William Osler. Thank you.